Hey folks, it's Beth Wright, and I'm providing you a podcast regarding corticosteroids as immunosuppressants, and this is for Unit 2, where we're talking about the immune system. So, glucocorticoids are used to help decrease that anti-inflammatory response and also to help with immunosuppressants, the system with respect to different autoimmune disorders, sometimes with organ donation or organ transplant clients as well. It's also used for anti-allergic or anti-stress issues. The agents, these agents, the corticosteroids, can be given IV, IM, local injection, subcutaneously, orally, topically, about any way that you can give a medicine, and they are widely used. They're really similar, or they are similar to the hormone cortisol and aldosterone. And so when we think about those two different hormones, cortisol, we should think sugar, and aldosterone, we should think salt. These are produced by the adrenal glands that sit on top of the kidneys. Therefore, one use is as a hormone replacement therapy for patients with Addison's disease, and those who have a pituitary or adrenal gland removed. And we'll talk more about that when we get to the metabolism unit of this course. Corticosteroids also have that anti-inflammatory property, so they're going to be used to treat diseases with an inflammatory component. And they are going to be used for immunosuppressant properties as well. So these abilities make the corticosteroids widely used and very beneficial in many disorders. However, the downside is a long list of significant adverse events or effects and the potential to cause adrenal insufficiency. The potential for adverse effects and adrenal insufficiency is increased when the corticosteroids are taken systemically and or at high doses and or for long periods of time. So the healthcare provider will make a decision whether the benefit outweighs the negative effects of this medication or these medications. The goal of therapy for corticosteroid use is to help reduce the symptoms. It is not curative, it's only used for palliative symptom management. And we want to do our best to avoid those serious adverse reactions that happen with corticosteroids. The drug selection factors is going to be, of course, why is it being used, and specific medication characteristics. And there's a long list of the medications, and so, of course, physicians going to make the decision on what to use. Again, they're extensively used, and it's based on the experienced effects of the medicines. Indication disorders include allergic or hypersensitivity disorders, collagen disorders such as systemic lupus, dermatological disorders, endocrine or gastric disorders. Endocrine would be like your adrenocortical insufficiency, gastrointestinal is used for treating the ulcerative colitis and Crohn's disease. It's used for neoplastic and neurological disorders such as leukemia, Hodgkin's, and multiple myeloma. Neurological would be like brain tumors, cerebral edema, acute spinal cord injuries, myasthenia gravis. It's used for ophthalmic disorders. It can be used for organ tissue transplants and for renal disorders as well. Respiratory disorders, asthma, rhinitis, it helps decrease secretion and inflammation. So lots of different respiratory disorders. Rheumatic disorders are going to be like arthritis or bursitis, and shock. Only for shock involving the adrenal corticosinsufficiencies, the adrenal crisis is when you'll see that used. So I've got you a pictogram, shows you the different types up at the top: methylprednisolone, dexamethasone, and prednisone. Notice ONE is at the end of those words, the generic names of those medicines. And I like this this pictogram, the good, the bad, the ugly. Talks about the drugs stop and control or reduce inflammatory response, both locally or systemically. Then the bad is normally there is a slow deterioration of the body. The trade-off is treatment with steroids in a chronic or autoimmune disorder, and that usually keeps the body healthier than in the inflammatory process was left unchecked. And then the ugly is the dose amount and duration of use dictate the extent of dependency and the damage to the body. So we got to watch for specific signs and symptoms. This does not include all of the signs and symptoms of adverse effects. We'll talk about those in a minute, but it does include a lot of them: edema, peptic ulcers, delayed wound healing, osteoporosis, and infection. Those are certainly some that we have to watch for adverse effects. Now, contraindications for the use of exogenous corticosteroids. Anybody with a systemic fungal infection, use in caution with patients with those who are at risk for infection, with anybody with infection, anybody with diabetes mellitus, anybody with peptic ulcer disease, inflammatory bowel disorders, hypertension, heart failure, renal insufficiency. Now, adverse effects, some of them can be expected, some of them may not happen at all, but we definitely got to watch for the adverse effects on there. So the first one listed is hyperglycemia, and you may have even seen a sliding scale for insulin with just, because of corticosteroids. So it will increase the glucose level. It is a hormone, cortisol. So think about sugar there. Corticosteroids have glucocorticoid effects that increases the release of glucose from the liver. So patients taking high doses of corticosteroids or taking them for long periods of time need to have their sugar checked, and they may even need to be on a sliding scale correcting the glucose level with insulin administration. The patient may develop a moon face shape and also have edema. So what happens there is the corticosteroids have the mineral corticoid effect, and that is the aldosterone, or the salt part. And it causes, when we think about salt, we should think about retention of salt or sodium in the kidneys. And anytime we retain sodium, we also will retain water. Remember the old saying, where sodium goes, water follows. At the same time, when we retain sodium and water, we are releasing potassium. We are excreting potassium. So we got watch about the water. and sodium, because it can cause us to have edema, it can cause hypertension, it can cause weight gain in patients, and we also have to watch about the potassium levels because they can fall, they can drop. So we got to watch for hypokalemia on these patients taking glucocorticoids or corticosteroids for long periods of time. Dietary recommendations would be something that would be good to teach with the patient here about decreasing sodium. They can stop using regular table salt and use a salt substitute, which is made from potassium. So that would help the potassium loss and help with retaining too much salt if they use a salt substitute. Also, we got to watch about patients who are taking loop or thiazide diuretics because those also can lower the potassium level. And so, we'll have a double whammy there if we do that. Patients who take corticosteroids systemically and are at high doses or for long periods of time may develop more fat in the face, and we call that a moon face. They may develop more fat between the shoulders at the base of the neck, and we call that a buffalo hump. They may develop more fat in the trunk of the body, while at the same time almost have no fat in the extremities, which is kind of strange. This can affect the body image and, of course, the self-esteem, so we need to know about nursing interventions on how to deal with that. Corticosteroids also have a catabolic effect. They, especially those who take them systemically or at a high dose or long periods of time, they'll have a breakdown of collagen. Also the GI lining, the gastrointestinal lining, and muscles and bones. Steroids that are like the sex hormones are anabolic steroids, and they build up the body. The decrease in collagen results in fragile skin and blood vessels and maybe, thinning of the skin. And patient may bleed easy and bruise easy and will tear easy. The skin will tear easy. And it may be difficult to start IVs on these patients because their blood vessels become fragile as well. GI bleeding can occur and lead to anemia and all of its effects. Taking the corticosteroid with milk, food, or antacids can help protect that GI lining. We as nurses should also be screening the stools of patients taking corticosteroids to make sure there's no blood, so hemoccult testing. Any drugs that can cause GI irritation, such as aspirin, should not be given to patients taking corticosteroids. Corticosteroids can produce a negative nitrogen balance, so increasing the diet of protein is recommended. Corticosteroids can also cause osteoporosis, so a nurse should provide teaching about increasing intake of calcium and vitamin D. And there are those that feel that corticosteroids can stunt or delay growth in children, so the agents should be avoided in children unless absolutely necessary. Infections. We know that leukocytosis and a risk for infection can occur with the use of corticosteroids. Because of immune suppressant properties, patients taking corticosteroids are at an increased risk here. And what is worse than infection than they develop may go undetected because of the anti-inflammatory abilities of the corticosteroids can mask the symptoms. Great care must be taken to avoid giving live virus vaccines to patients with corticosteroids because they may actually develop the disease the vaccine was given to prevent. because of the anti-immune effects of corticosteroids. And corticosteroid eye drops are contraindicated when a patient has a viral infection of the eye. Also, let's talk a minute about the adrenal corticosteroid insufficiency that can happen with patients. So the hypothalamus only has the pituitary gland release ACTH when levels of serum cortisol is low. When a patient takes a corticosteroid, the hypothalamus thinks there's plenty of cortisol in the blood, and because there's no ACTH released, and since ACTH is not stimulating the adrenal glands to release cortisol, over time the adrenal gland will atrophy because, if you don't use it, you lose it. Suddenly, the patient stops taking the corticosteroids, and the atrophied adrenal gland will not wake up and produce cortisol. So this is really dangerous, as cortisol is one of the stress hormones that keeps us surviving stressful times in our life. We have to have it. Therefore, anyone taking corticosteroids or takes them for a period of time, systemically taking them as well, or PO forms of it as well, they should be weaned off of the corticosteroids so that the adrenal gland can have time to wake up and start building back the cortisol in the body. Medical alert identification is very important in case of an accident for patients who are on corticosteroids for long term, and we need to be knowing signs and symptoms of adrenal insufficiency to monitor the patient who are being weaned off of corticosteroids, and teaching the patient about this so they can alert the healthcare practitioner if noted. We want to avoid the adrenal crisis where the patient will be extremely ill. So, signs and symptoms of adrenal insufficiency are hypotension, restlessness, weakness, dehydration, and nausea and vomiting. Also, this corticosteroids, we talked already about, affects the calcium, putting the patient at risk for osteoporosis and fractures. It also puts the patient at risk for cataracts and glaucoma. And also, it can have a CNS stimulation effect where the patient's mood is anywhere from euphoric to depression. Insomnia can occur, and so it can be problematic for patients many times with the CNS system. So this is a picture of a patient who has systemic lupus, and we're going to talk just a minute about what kinds of things we will do for her. But if you see her classic sign there is the butterfly rash that's on her face. That's what they refer to it, and they can have all kinds of skin rashes as well. Other signs and symptoms is fever, joint pain and inflammation, fatigue, kidney damage, and fluid retention and anemia. Heart disease can occur also with lupus, in some cases leading to death. So the sac around the heart can actually become inflamed with pericarditis, endocarditis, myocarditis, and coronary artery disease. And they can also be affected with lung disease with SLE. So a patient is treated with prednisone 50 milligrams daily. Based on all those adverse effects that we have talked about, I want you to look at think about, write down the different teachings that we would do with this patient with respect to cortisol and respect to corticosteroids. Now I have sample questions for you. And so when we look at the question, the nurse knows the patient understood teaching related to prednisone for immunosuppression when the patient states which of the following. So A, I will notify my healthcare provider if my glucose levels rise. Okay, does your glucose level rise when a patient takes corticosteroids? You got to know that. B, I can take my medication with orange juice each morning. C, if I miss a dose, I will double up on a dose the next day. And D, I can expect to lose weight while on steroids. Okay, so the correct answer, hopefully you selected A, because it will affect the glucose. And it requires close monitoring. Another sample question, and the nurse is evaluating the effectiveness of corticosteroid use for the treatment of systemic lupus. Would consider the medication effective when the patient so is the med working when they gained 10 pounds since the last visit 3 months ago? And again, we are evaluating the effectiveness of the corticosteroids. We are not evaluating adverse effects, but we are evaluating the effectiveness. So it's very important in that STEM. Is able to dress and feed themselves each morning. Okay, so with that choice, you got to know, okay, does systemic lupus cause fatigue? Cause problems with, movement, mobility, that kind of thing. C, begins to spill protein in their urine. Now that doesn't sound like a good thing, does it? Okay. Or D, develops a rash over their upper back and shoulders. And that doesn't sound like a good thing either. So the big thing with this one is you got to know about the disease process, and that's how we're going to know that it's better. And it is B, is able to dress and feed themselves each morning, because the drug works the way the purpose and how it's working for lupus is that it decreases that inflammation in the joints, and the patient is more able to move and is in less pain and being more active. Okay, that concludes this podcast.